It's beginning to look a lot like Christmas, and happy holidays to all of you. And it is just after Thanksgiving. I'm recording this lecture. As you can see behind me, we're in my house here. Have the tree up now. Hope you guys are enjoying this time of the year, the holidays coming. Whatever you may celebrate, I hope you have a wonderful holiday season. And we'll get into this next lecture, which is going to be shoulder differential diagnosis, but with inert tissues, common inert tissue pathologies. Hopefully this is a little faster lecture than last time. The contractile tissue one is important because of the rotator cuff, and I'd say the big dog here is going to be the labral pathologies, right? Those are all the most common things. So if we jump right into it, looking at inert tissue pathologies today. So objectives, we're going to try to understand the following differential diagnoses. Looking at glenohumeral or glenoid capsulolabral pathologies, including anterior, posterior, slap, and multi-directional instability / labral issues. We group together the term capsulolabral because, as you'll see in a little bit here, the joint capsule and the labrum are intimately connected and related, and they have a similar function. We'll also look at a type of sprain of the shoulder, AC joint. It's the most common sprain of the shoulder, and then the glenohumeral osteoarthritis, as well as the adhesive capsulitis. So what does inert tissue mean? Well, it's joint capsule, cartilaginous, chondral, ligamentous, and many more. Basically, it's anything that does not contract. And so, we can go into even neural. Some people argue neural tissue. Some people argue neural tissue does contract, but we think about like venous system and that sort of thing. Those are all types of inert tissue. Bone is inert tissue, but we'll go over the ones here. We're gonna have another lecture on neurovascular as well as bony anatomy as our third in this series to wrap it up, but let's get after it here. So glenoid capsulolabral pathologies. The first one here is anterior capsulolabral injury, aka a Bankart injury. And so I think it's important that we review real quick the anatomy of the capsulolabral complex. And as you can see here, is you have the face of the glenoid, and then you have the labrum, which surrounds that, as you guys know, and then you have these different projections that come off, which are your ligaments. And right, you have your biceps tendon at the very top, and then your ligaments, superior, middle, anterior, inferior, and posterior, inferior glenohumeral ligaments that help stabilize the joint. So these are your inert stabilizers. Obviously, your dynamic stabilizers are going to be your rotator cuff muscles and deltoid and things of that nature. So if we move on, this is just another picture here. I think that helps you visualize this. I'm a visual learner. Hopefully you are too. This is someone's left scapula. Here's the spine of the scapula. Here's the body. Inferior angle is down here. Here's the anterior face of the glenoid. This is the biceps tendon coming off the top, right? So then you have your four ligaments that surround. And what they've done is they resected the joint capsule, which you can see in this picture. This is a right one. So if you flip this image, you can see that this joint capsule is connecting each ligament. And so this creates a sling effect, essentially, of the joint capsule as well as the labrum and the ligaments. They all work in concert together. Here's the glenoid, or rather the humeral side. Here's the glenoid side. Here's just another illustration of where those ligaments are in relation to what we consider a clock face of both the humerus and or the glenoid. And so in postoperative cases, you'll need to know this better, but this is just a reference slide. You won't need to really know this for the test. So shoulder instability, what is instability? Well, let's define our terms. So instability is the quality or state of being unstable, lack of stability or firmness, and the tendency to behave in an unpredictable, changeable, or erratic manner. Laxity is the state of or quality of being lax or loose. And so you have humans that have both of these. One, laxity may be one's genetic predisposition, of tissue elasticity or extensibility. This means they have no pain. They're just very flexible. We all know people like this. They could include genetic tissue disorders like a high Beighton score index, and then rare conditions such as Marfan's or Ehlers-Danlos syndrome. Those things take into consideration. You can see Michael Phelps here, obviously hyperhorizontally abducted, as well as elbow extension greater than 10 degrees. Obviously, it's a big angle. You can see that his digits are very long and skinny. I think he may have something like Marfan, some connective tissue disorder. So, as we move on here, instability can be characterized according to several different factors, and the big ones here are direction, etiology, degree, frequency, and volition, and we'll dive a little deeper into all of these here as we go. So etiology, we're thinking there's three big types. One is what we call an ambry, which stands for atraumatic, multi-directional, bilateral. Bilateral meaning both sides obviously are affected. Rehab is the first line of defense, and then if rehab has failed, then an inferior capsular shift surgery may be indicated. TUB stands for traumatic unilateral Bankart injury, which is an antero-inferior injury to the labrum, and surgery is likely indicated to fix that. And then finally, you have your repetitive overuse injuries like your SLAP lesions or your micro instabilities or your sometimes your multi-directional instabilities are categorized here. So multi-directional instability may also be here, and we'll go into what that actually means. This is just a flow chart I like. It helps my mind visualize it, so you can pause and look at that if you'd like. Another thing for us who are visual learners is this instability spectrum. So your congenital ones are your ambry patients. Those are people who are born loose. They have the hypermobility, passive range of motion, just like this individual here. Then you have your repetitive stress. This is more like a SLAP tear, which stands for superior labral anterior to posterior tear. Those are your worn loose, so things like pitchers, swimmers, things like that. And then traumatic cases, so people who have their shoulder forced into abnormal maximum ranges of motion. Those are your TUBS patients, your traumatic unilateral Bankart surgery patients, torn loose. And this last weekend, so I live up in Minnesota, and we work with the Minnesota Vikings occasionally. And so this is Dalvin Cook, who just diagnosed with a shoulder dislocation this past week. So hope he gets better soon. Stability and mobility of the shoulder is a sliding scale. So if we look at it, you can be someone who's very rigid or someone who's very hypermobile, but you're going to fall somewhere on this scale. And so your hypermobility, your shoulder dislocation patients or ambries, TUBs, they're all going to kind of fall on this side usually. It's tougher rehab, especially multi-directional instability be way over here. I think it's important to know that. So we would give them strengthening exercises to slide them back, right? And if someone's very stiff or rigid, we give them flexibility exercises to slide them to the right. Degree is another one of those things that we think about with shoulder instability. So degree, there's three types of possibilities here with this injury, and we're thinking about anterior instability, or really anterior or posterior. But if we start from the bottom and work the way up, apprehension is the first one. So just getting to a position where you don't feel like your shoulder wants to go any further, you feel like something bad may happen. Subluxation is when you actually have a shift of the humerus to the edge of the glenoid rim and then shifts back into its normal anatomical position. And then finally, a dislocation is a full shift of the humerus off the glenoid, and may need to be reduced by a medical professional, but it also may spontaneously reduce as well. So frequency, here we have an acute injury, is like a recent traumatic injury. We would classify it as an acute injury. A recurrent injury is someone who has shoulder instability and has become what we think of as a serial dislocator. So they may have bony loss or soft tissue inefficiencies, things like that, that put them in a position where they dislocate more often. And so Anyone under the age of 20 with shoulder instability, it's very common for them to have a recurrence. Anyone over the age of 40, it's uncommon just because, people in that age group are not participating in activities that may dislocate their shoulder as much. And then chronic, this is someone who has a history of shoulder instability with no recent events, but they may have pain or dysfunction secondary to poor motor planning and deconditioning. And then finally, here's volition. So you have someone who can voluntarily or involuntarily sublux their shoulder. And there's maybe someone in class that's like this. So these are your born loose people. You can take a look at this slide, of course, and then try this on yourself. So observation, what do? We want to do a clinical assessment, medical screening. Do they have a connective tissue disorder? Functional tests like the Beighton score, and observe anything like scars or skin extensibility that might give you a clue into their elasticity, their genetic elasticity. Here is a picture of the Beighton score. You guys should have already gone over this at some point, and if not, we can certainly spend some time doing it, but I want you to pause here and just look this over, obviously. And then finally, diagnostic imaging. And the reason we get this someone who has shoulder instability is we want to see if there's any bony loss. This component here is the rim of the glenoid. This is someone's left shoulder, AP view. And so what's happened is this ball has shifted anterior and inferior off the socket, and what you get is a fracture of the glenoid rim, and then likewise a compression fracture in the back called a Hill-Sachs lesion. And these are, for your point in your career, good to know information. I would know that I would look these up and know what they are, but we can dive deeper into like office hours if you guys want more information. So we're going to get right into anterior shoulder instability here. All right, so here we go. So as you can see from the model of last lecture, I've set this up to look similar. So again, I'm not going to spend all the time here going over every bullet point. These are for your information, and these are free game on test, the bullet points that we have on these sections. But for the sake of your time, you can look at the slides, of course, and pause it as needed, write down notes, send me questions. I like to do it something like that, but we'll go over the big bullet points. So essentials of diagnosis for anterior shoulder instability. 90% of cases of shoulder instability are anterior in direction. Usually the mechanism of injury is traumatic with a fall and an outstretched arm, usually in the externally rotated and abducted position. Sometimes hyperhorizontal abduction happens or hyperextension. And if you look at all these three positions, it's important to note that these are all arthro and osteokinematic positions that create a slide and glide in the anterior direction. And so that's important to really realize why those positions cause this type of dislocation. The demographics here is you're going to have usually young athletes are most commonly affected. Males are more often affected than females, especially traumatically. All right. So signs and symptoms, really going to have apprehension, and that's what the picture on the right is showing, especially acutely. You're going to have clicking and popping of the shoulder, likely because of a labral injury, and then special tests for instability are going to be positive. Functional implications, obviously, these patients are going to have difficulty, especially early on with overhead activities and range of motion and weight bearing and things like that. So possible contributing causes, well, this is traumatic in nature. Again, hyperhorizontal abduction, external rotation at 90, and or falling on an outstretched arm. Usually athletes who are already really flexible, like swimmers, gymnasts, or overhead athletes, if they sustain a traumatic event, they can dislocate their shoulder. If they have increased joint laxity elsewhere, like a high Beighton score, that might cause an issue here. Differential diagnosis, we're thinking a Bankart lesion, anterior, so that's going to be an anterior capsulolabral injury. We also may think of a bony Bankart, which is that fracture, of course. We think maybe a humeral avulsion of the glenohumeral ligaments, which is called a Hagel lesion. Hill-Sachs lesion, which is a bony impaction fracture of the posterior humerus, and then maybe a reverse Hill-Sachs lesion, which is posterior dislocation. You have an anterior bony injury in that case. Test and measures, the apprehension test and the relocation test are the top two there, and those are the best ones to really get a sense here. You can also do the test at the bottom there, which is the anterior slide or drawer test. And then, of course, load and shift and sulcus sign are good ones for shoulder stability. You will get an MRI to visualize the scope of the tear, and also an X-ray, just plain film X-ray to see if there's any bony injuries. So again, what does your intervention in PT look like? If you don't get surgery, a lot of people choose not to get surgery when they've dislocated their shoulder, and that's okay. Acutely, you're just going to treat it. You got to understand their stage of healing, how long out are they from the injury, and then start working, some gentle, pain-free isometrics and range of motion, maybe a little gentle weight bearing if they can tolerate it. You're being cautious with the positions that may cause this injury. We're talking about external rotation, especially up in the abducted position, or anything where your hands are getting outside of your field of view. When you look straight forward, those are positions that may cause instability. And then the intermediate and advanced phases, you're progressing with strength training, weight-bearing exercises, proprioception, scap and cuff program, until finally getting to plyometrics and return to sport interventions. All right, posterior shoulder instability. Mechanism of injury here is usually traumatic. It's a fallen outstretched arm, but not really in an extended position, more in an axial loaded position, or it can be due, and this is most of the cases, repetitive microtrauma, like football linemen who have repetitive posterior axial loading of their shoulder. Also, bench pressers and people who work out a lot may start to have posterior shoulder instability. And really, it's not, especially in repetitive cases, it's not instability that's noted. It's mainly pain or weakness is a limiting factor, and it's hard to dislocate the shoulder posteriorly. It does happen. However, a traumatic event needs some serious force. So the demographic here is there's significantly greater incidence of posterior shoulder instability in males and females. Both sexes peaking at 14 and 19 years, and incidence rates remaining elevated throughout the third and fourth decades of life. So this is mainly for your younger, active individuals from your teenage years to 30s and 40s. Posterior instability accounts for about 1 to 5% of all instability cases. Some studies show up to 10%, but it's definitely much, much less than anterior shoulder instability. So signs and symptoms, you can see the picture on the right is a picture of someone with scapular dyskinesis. And, anytime someone injures their shoulder, they may have start to guard and compensate and develop poor motor patterning. In this case, I'd also want to see if there's a neurological issue as my differential diagnosis. But, you may see some scapular dyskinesis, and that's fine. But shoulder weakness, and the big one is posterior shoulder pain is the big dog here, and what people complain of when they have posterior shoulder, quote-unquote, instability or labral tear. Functional implications, you're going to have difficulty lifting, reaching, and weight-bearing, and trouble with reaching behind the back and across the body. So our differential diagnosis includes slap tears, posterior or internal impingement, suprascapular nerve palsy, and multi-directional instability. And here are some special tests you can do for posterior shoulder instability, including the posterior load and shift and the crank test. But the pictures we have listed here is the top one is the jerk test, and then the bottom one is the Kim test, which is a two-part test. And I encourage you to look up in Dutton those tests. It's important in diagnosing, because the combination of the jerk test and the Kim test has been shown to be 97% sensitive for detection of posterior inferior labral tear. And so those two in combination are good ones to use for practical purposes. And of course, a posterior apprehension test, which is going to be more like your axial loading or scour test. If we go back one slide here, skipped one, sorry for that. Posterior shoulder instability intervention. So throughout rehab, you just want to be having caution to taking the patient into axial loading, especially a combination of axial loading, internal rotation, and cross-body positions. So this looks very similar to the anterior shoulder instability interventions. However, you will probably want to avoid closed kinetic chain exercises earlier on, whereas in anterior instability, you can start those sooner. So I encourage you to pause this and then look at the slides here. So next we're going to talk about superior labrum anterior to posterior tears, or SLAP tears. So what is a SLAP tear? Well, do we have superior instability? We don't really have true superior instability, but because if you think about what the roof of the shoulder is, you have your acromion and basically your acromion and your clavicle, right? Your AC joint area, that subacromial space is the roof, and so you can't really dislocate superiorly. So the tissues that are involved in the top of the shoulder are the ones who take the brunt. It's going to be your superior labrum, rotator cuff, and those structures. So the mechanism of injury for a SLAP tear is going to be quick traction or overload to the proximal long head of the biceps brachii tendon, and shear force then as shear force to the biceps during a fall and outstretched arm, or sudden forced abduction, external rotation, causing a peel back moment. And that's what we can see here. It's like a wringing out of a towel. As you externally rotate your arm back to throw a ball or swim or something like that, the biceps tendon will go into this spin, or this wringing out effect, and it'll put tension through the superior part of the labrum, which can cause over time a peel back mechanism or peel back effect of the superior labrum. So as we move on here, again, same thing as I mentioned before on the previous slide, just with pictures to help you visualize it. This demographic is usually throwing and overhead athletes. Once you stop playing sports, it's hard to get these. Maybe if you're a weightlifter or something like that. But typically non-op management is the initial treatment, and those are probably the best treatment approach because surgical intervention, especially in the overhead athletes, don't have very good outcomes. Signs and symptoms, you can see how much external rotation this pitcher has. He plays for the Diamondbacks now. His name's Madison Bumgarner, and I think he does now play for the Diamondbacks, but you can see how much external rotation he has, 160 degrees or whatnot. So signs and symptoms are pain with the max cocking or layback phase, as well as deceleration phase, because of the deceleration of the arm, the biceps brachii has its highest peak EMG, so we might get pulling through the labrum in that position. And then, of course, diminished ability to perform sports, clicking or catching, deep pain within the back of the joint, pain with throwing, and pain with overhead lifting and reaching. Differential diagnosis includes anterior or posterior labral tear. Who would have thought, considering this is a superior labral anterior and posterior tear? But you might have your differential include those two. Posterior internal impingement, suprascapular nerve palsy, and then multi-directional instability are your big ones. So tests and measures, you can do the biceps load test, which is that picture on the left. And then, of course, the pain provocation test, which is the picture on the right. And this one's essentially, you're going to externally rotate the patient's arm into the throwing position while you provide an anterior glide to the shoulder, and you're going to ask them to resist a biceps in this position. So there's some other tests you can do, like Speeds and Jurgensen's. Both, these should look familiar from your proximal long head of the biceps brachii tendinopathy special test. Interventions, you're going to try non-operative treatment first. Of course, just like anything else, pain and inflammation reduction, try to restore motion, strengthen the cuff and scapular stabilizers. But if they're not improving, should we move on to surgical management? Well, there's some studies that show that a SLAP repair, actually inhibits the shoulder from externally rotating as far as it should. So maybe what we do is we cut the biceps tendon, do what's called a biceps tenodesis, which is we reattach it down the humerus a ways, and so we just debride the labrum. And if you're interested in learning more about that, look it up. But on the right side, you have your 4 big types of SLAP tears, and the ones on the right, B and D, those would be SLAP type 2 and SLAP type 4, are the ones where you have an unstable biceps anchor, and those are the ones that might need surgical repair. Now the one in the bottom left is a type 3, and you can see that's a superior labral issue, but the biceps anchor is intact. And then a type 1 is just fraying of that tissue. So multi-directional instability, we also call this MDI. This is going to be glenohumeral instability that is present in more than one direction. And remember, we think about laxity versus instability. Laxity, there's no pain, so someone could be lax You want pain in two directions. So it could be someone always usually has inferior instability, meaning pain in the inferior direction, and then usually one of the other of anterior or posterior. So the rotator cuff pain is usually the first presenting symptom because these people have secondary impingement syndrome, usually from poor scapular stabilization, and they have poor motor control of the scapular muscles. So they get repetitive overuse of the rotator cuff in that case with things like especially gymnastics and swimming, sometimes weightlifting, but these are all people who might see it. These are your genetically loose ambry individuals. So differential diagnosis would include, rotator cuff impingement, scapular dyskinesis, anterior, posterior glenohumeral instability, and then I always think about nerve palsies. They pop up more than you might think. And then tests and measures. Sulcus Signs, the big one. That's the picture that's demonstrated here. If you provide an axial load downward, axial traction, you'd see this space between the superior part of the humerus and the acromion create this space here. And then this is that picture again of someone being able to volitionally do it just by contracting their pec muscle. They can pull their humerus forward. So there you have it. So what do we do for interventions? These people need stability work. So tons of closed chain work, tons of band work, tons of scapular stabilization work. Hanging is really good if they can tolerate it. Maybe do something like a TRX where you're doing modified hangs. But anything that's going to help co-contraction of the rotator cuff is really, really good. So you guys will, of course, learn more about this as you go on, and I encourage you to try things in the gym there at school to see how things feel. If you need to take a break, it's a good time. We're done with our labral pathologies. We're going to move into AC joint sprain. All right, I had to take a quick break myself, so back with AC joint sprain. So let's talk about the anatomy of the AC joint. And so there's really three big ligaments here that I want you to be aware of. Of course, it's the AC ligament, which connects the acromion to the clavicle. And within that, you have a joint capsule as well as a meniscus that helps the joint articulate. And so those are all structures that are neurovascularized that can be injured. And we'll talk about what the injuries looks like moving on. But I also want you to really take note of what we call the CC ligament, which is the corticoclavicular ligament, because when you sprain your AC joint, you may tear those as well. Those are two ligaments, your trapezoid and your conoid ligaments that may become injured. And then your coracoacromial ligament is sitting there as part of the, if you guys remember from last lecture, the coracoacromial arch that makes up that space where you can get impingement at. So I just like to point that out as well. There is 6 types of AC joint sprains, and they're graded from 1 to 6 in order of the most least severe to most severe. And so you can pause it here and look at this. Usually types 1 through 3 are all managed non-operatively with physical therapy. However, types 4, 5, and 6 usually need surgery, especially the number 4, which is a posterior dislocation. That's going to be, unfortunately, you think about what's behind that area. You have your brachial plexus and maybe some neurovascular structures there. And then number 6 is an inferior dislocation, which actually tears through some of the pec minor and the biceps tendon, and it's just a nightmare. I've never seen one in real life. I talked to a doc. He said he's never seen one, but these are going to be like car accident. People have much more going on, and yeah, it's just a bad situation if you're a grade 6. So essentials of diagnosis. So real quick, let's go back. So the first 3 is what you'll be seeing in clinic. And I just want to point out here that grade 1 is going to be, this is not your grades of sprains where you have grade 1 is, intact, but it's irritated fibers of the ligament. Grade 2 is a partial rupture, and grade 3 is a full rupture. This is grading severity of AC joint sprains in particular. So you have irritation to the area in grade 1. A grade 2 is just the AC joint AC ligaments torn, causing instability, and then a grade 3 is a full AC and CC ligaments are torn. So you can see this is different than typical ligament sprain. Just want to point that out. So diagnosis is made usually through an x-ray because the people here usually point tender right on the tip of their shoulder, and they will really point to it and be very obvious as superior shoulder pain after some sort of trauma. And then also known as separated shoulder or AC separation, AC dislocation, shoulder separation. These are all common terms used. You could get osteoarthritis years following this injury, especially if you have a big instability event. But demographics, usually individuals with a history of activities involving overhead, including swimming, tennis, baseball, but really it's traumatic in nature, like falling onto the tip of your shoulder. And speaking of which, here we have a picture of a football player falling onto the tip of their shoulder. So again, signs and symptoms here, you think about what compresses the AC joint, what compresses that meniscus that lives between the acromion and clavicle. And that'd be things like reaching behind your back, internal rotation, cross-body, axial loading. You have an ache in the anterior and top aspect of your shoulder, pain with palpation. You may have a step-off deformity of the clavicle and acromion, which is in a slide coming up here. And then functional implications, obviously may limit overhead activities, especially with lifting, throwing, and other rapid arm movements. So the big one here, contributing factors, landing on the lateral tip of the acromion. Differential diagnosis is rotator cuff tendinitis or impingement or tears, bursitis, biceps tendinopathy, biceps tear, labral tear. Remember the coracoacromial space. You just want to rule out all this other stuff. Here's a picture on the right of both imaging and visual inspection, which is going to be part of your test and measures. And you can see how you have a superior migration of the clavicle in the picture on the top right in the x-ray, and that's what we call a step-off deformity in the picture on the bottom right. You can see that this individual has AC joint instability. So this would be a grade 3 at the minimum, maybe a grade 5 if we go back and look at those pictures. So special tests, the acromion shear test, O'Brien's test, AC resisted extension test, crossover impingement to sign, and a pain provocation test as well may hurt. So what can you do? Well, acutely, you're going to rest and reduce inflammation, use modalities, gentle stretching, range of motion, maybe tape the AC joint. And then this picture on the right shows what we call an AC offloader. This is a kind of a specialized one you could wear under shoulder pads or under your jersey, something like that. But you can also just get a foam pad and create a donut per se to offload the joint. And then post-acute, we're going to just try to progress as tolerated. So these after about 3 or 4 weeks, these injuries are self-limiting. So we're going to work on range of motion and strength, progressive closed chain exercises once they can handle it. And then finally, in a chronic case, and I'm thinking usually 8 to 12 weeks out, we're starting to increase weightlifting and stuff to their tolerance. And these can stay buggy for a long time. And if you start loading them too quickly post-injury, where your body doesn't have a chance to really heal this, it can be chronic. So not good. Glenohumeral osteoarthritis is next. So, OA is also known as degenerative joint disease, and that's kind of a scary thing for a patient to hear. Degenerative joint disease. It's like, no, not really. It just means you're getting older, and you've probably been active, so that's good. So it's associated with increased age, maybe obesity, previous trauma, definitely, previous surgery, abnormal loading of joints over time, and characterized by global joint pain. And this is pretty much common for all types of OA. So, the big general considerations is that you're going to have bony changes on imaging, and then overall joint dysfunction, like you might feel like your joint's swollen or inflamed, have joint pain, morning stiffness, secondary problems of muscle atrophy and weakness, may have bony protrusions or prominence from Wolff's law of abnormal loading within the joint. You may have crepitus, things like that. So demographics, more common in middle to older age populations. Women are more commonly affected than men. There's more common in African American and Caucasians than other ethnicities. And then post-traumatic osteoarthritis. So these might be younger individuals with history of joint trauma or surgery. We're talking about people who've like had your anterior shoulder dislocation, as we mentioned earlier. Later in life, they might develop earlier onset of OA. And military population may have an early onset as well because of their labor-intensive jobs and combat and things like that. So signs and symptoms. This is like your typical patient that that has OA looks something like this. A little more elderly, a little overweight, maybe not in great health. So we'll just leave it at that. Okay. So joint pain and aching, joint stiffness, muscle weakness and atrophy. Crepitus is a big one. Loss of range of motion, and so on and so forth. Functional implications: they have limited mobility. They have trouble with ADLs, decreased overall activity and participation. So, possible contributing factors, obviously aging's the big one here, but previous joint injury, if I haven't made myself clear there. Differential diagnosis: we want to rule out rheumatoid arthritis, things like gout, rotator cuff tears in the older individuals, bursitis, tendinitis, adhesive capsulitis, which is what we'll talk about next, but you have loss of range of motion there. And then things like pain syndrome. So the reason we have pain syndrome like fibromyalgia is because OA is kind of a globally irritable diagnosis of the shoulder. It doesn't just present anterior or posterior. It's kind of a global irritation of the shoulder. And then other types of joint issues like spondyloarthropathies may be a differential. So tests and measures, the big one here is going to be get a conventional radiograph of the joint. You kind of put together they're having shoulder pain, it's come on progressively over time, and they're older. And so you go, those three factors, you're going to go, okay, let's get some imaging. And morning stiffness is another one. So, on the left side here, you see what a typical normal shoulder looks like. Good joint space, good margins, no real bony protrusions or bone spurs. And then the picture on the right, you can see decreased glenohumeral joint space, a big projection off the humerus here, and bone spurs throughout. So this would be considered as osteoarthritis. So what do you do for interventions? You really just try to keep these people as active and mobile as they can. And a lot of them just need consistency with training program, and they'll usually start feeling better. They may have to do modifications, of course, because of pain or irritation, but consistency over time has been the thing that's helped my patients the most. So you may also want to look into things like diet modifications for inflammation, do maybe non-conventional or holistic approaches as well. Acupuncture, dry needling is really good for pain management, and then patient education. So you want to get these people moving. They still have the capacity to feel better in most cases. All right, guys. The last one here is adhesive capsulitis. We'll try to make this one quick. So frozen shoulder. So the picture on the right, just before we move on, is the stages of adhesive capsulitis. And so you have stage 1, 2, 3, and 4. And I want you to just pause this and look through this. Adhesive capsulitis is also known as frozen shoulder. So you have your acute stage, your freezing stage, your frozen stage, and then finally your thawing stage. And look this over. And I'm also going to attach an article, which is the clinical practice guidelines for adhesive capsulitis from the Journal of Orthopedic and Sports Physical Therapy, so you can look that over as well. But this is a self-limiting shoulder pain and dysfunction due to what we think might be like localized inflammation of the glenohumeral joint capsule, or irritation of the synovial fluid, or fibrosis of the capsule causing adherence to the humeral head. And so what happens is you just get your joint capsule just gets really, really stiff. And so you have no capsular mobility, so then you can't move your arm. So we think there's three pathological pathways. One is idiopathic, meaning we have no clue why this happens, but there could be a secondary cause or what we might know as a tertiary cause, which is going to be your maybe post-traumatic or post-traumatic, so that'd be like post-operative or post-fracture. And secondary causes could be, well, we'll talk about that, I guess, in the next slide here. So extrinsic, intrinsic, and systemic factors are your secondary factors. And so I'll have you pause this and look at this, but the big one here is a humeral fracture, right, which could also be a tertiary, right, post-traumatic. And then, you know, your intrinsic factors, rotator cuff tears, irritation, your body might respond negatively to that and cause this disconnect between threat versus real damage. And then the big one here for systemic factors is both thyroid disease and diabetes. So these, for some reason, are related to frozen shoulder. And if we look at the demographics here, 10 to 38% of people with thyroid thyroid disease or diabetes gets frozen shoulder. So 1 to 4 out of 10 people with those diagnoses get those things. So gets frozen shoulder. So it's usually in people from 40 to 65 years old, females more than males, and then the reoccurrence, I should say, or the contralateral occurrence is anywhere from 5 to 34%. And this is a very, very, this is a tough diagnosis. It's tough to treat. It's a long process, and it's really tough psychologically for the patient because they feel like they're affected negatively for a long time. So these are actually really hard cases. Signs and symptoms, well, you're going to have your big hallmark here is loss of range of motion in all planes. So internal and external rotation are severely limited. And if we can look at the picture on the right here, this top picture is her affected arm. You can see her external rotation here versus her unaffected, internal rotation here versus unaffected. She can't even abduct up to 90 degrees in this picture. And then here's reaching behind her back, left versus right, or affected versus not affected. So it's a tough case. So again, possible contributing causes: humeral fracture, history of trauma, diabetes, thyroid issues. Differential diagnosis want to include cervical radiculopathy, full thickness rotator cuff tears, because again, they're going to be super stiff, can't lift their arm very well, so you might think, oh, it might have a rotator cuff tear. Neuropathy, things of that nature are the big ones, I think, are your differentials. So tests and measures, not really any real special test, but all impingement tests will be positive. Differential just includes really range of motion loss in all planes. Impingement, to differentiate, will have pain-induced range of motion loss in 1 or 2 planes, but not all planes of motion, like true adhesive capsulitis. So basically the takeaway here is if you have a middle-aged female with diabetes or thyroid issues that has shoulder pain, you're thinking adhesive capsulitis right away. Interventions, well, you know, if you look back at the thawing, the freezing, frozen, and thawing stage, that will help you get an idea of what you can do within those different stages of this. But you know, you want to work on range of motion essentially. So you can pause this and look at these intervention ideas and get in touch with me if you have any questions about them. This is the clinical practice guideline. I'm going to attach to your PowerPoint here. I encourage you to look it over. It's something like 50 or 60 pages long, but you can certainly get through it. It's not that intimidating. So you won't need to read every page of it, but at least skim through it and look at the big bullet points, okay? Thanks again. You can shoot me an email if you have any questions. We will be discussing office hours soon. So if you guys need anything, just reach out, okay? Thanks a lot. Appreciate you.